Having a Kevin makes all the difference.
We all need a Kevin.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
All right, the door is open. I'm going to hope that UPS doesn't come.
Oh, because then the dogs go completely berserk.
I only have one at home right now. The other one is the shepherd is at the kennel. I have to go out of town for some work tomorrow morning. So the lab can stay with the neighbor and stuff. The shepherd cannot.
There's that. Not dog friendly.
No, she loved you. She's just a lot.
Okay. Yeah. And there's only so much that you can ask a neighbor to do and still be a good neighbor.
For sure. The lab, he's old. He doesn't need much. The shepherd needs a lot.
Yes, has a lot.
Yeah. And this will be my segue to some of the things I wanted to talk about. Patients come in all different shapes and sizes with pathology and history and stuff. But what I think I wanted to bring the point across is that I feel everybody needs to be on a maintenance plan.
Yeah, assuming they can afford a custom care.
Yep.
And or those of you that have regular practices where they just, the way I used to do it was twice a week for 4 to 6 weeks. Then they get better.
Yeah.
You say, okay, come in once a month for lube, oil, and filter.
Yeah.
Just maintenance. Or come back in when you do something dumb.
And I think, right, I don't want to say maybe dumb, but if we have athletes of whatever type of caliber, there's going to be something. And lately I've had people that were quote unquote fixed that came back with something new or something different. They're like, geez, I just really thought I'd be done. And I'm like, as long as you're moving and breathing, things are going to happen.
Yeah, that's the thing. That is true.
So I think explaining to people that you're never done, the maintenance, and especially if you are active, regardless of your age, you're going to need that lube, oil, and filter just to keep things running. And there's no shame in that. There should be, it should be an exciting time I love it when people come in and they're like, I'm like, how's everything? Everything is great. I don't really have a complaint. Great. Let's do an assessment. Let's see what we find, because I love that you're feeling good, but let's make sure you're staying good. And that's where like the kinesiology, the biomechanics, that's where reflexes, however you do your physical exam is so important.
You can always tweak something.
Right.
And that, I think that's why I framed it as lube, oil, and filter.
Yeah.
It's like you do maintenance on your car's still running.
Right.
It still gets gas mileage. It still doesn't make noise, but once every 6,000 or 8,000 miles, you take it in for lube, oil, and filter, and they check the fan belts for wear, and they check the brake fluid to make sure it's not dirty, because that doesn't show up. And by the time that shows up, the brakes are toast.
Right.
So whereas a lube, oil, and filter costs $80, if your brake fluid, transmission fluid, differential fluid, whatever, if that gets nasty and not normal, then it's $400. So it's pay me now, pay me later. It's like, it's a lot easier to just do it that way.
Or you could use the dental hygiene analogy, right? Like you don't just go to your dentist, hopefully, when you need a root canal. Hopefully you're going twice a year for the cleaning and the checkup, where they can treat the cavities before they're a root canal. So that was part of what I wanted to touch on.
No, I totally agree. And it depends on the financial demographic.
Yeah.
And what your license is.
Yep.
Oh, sorry, I just had a horror story from this week that I have PTSD from.
We'll talk about it. Let's talk about the fun stuff first. We just scare everybody in the first 5 minutes of.
It wasn't exactly, anyway, it's you twice a week for 4 to 6 weeks, and then come see me in about a month to make sure it's holding and everything's behaving itself.
Right.
And then maybe come see me every 2 months. And then if your office is set up to send out reminder cards, like the vet does when it's time to update vaccines, or the dentist's office sends out the cards to remind you. You can that's easy to set your office up, have those printed, and then patients that come in this week get a reminder. You give it to your receptionist or yourself, and you put it 6 months out or 3 months out.
And or my software does it now too. If somebody hasn't been in 6 months, hey, it's been a while. How are you doing? Blah, blah, blah.
Yeah.
And then for the PTs of the group, or even going back to what we do in the sports course and the sports advance, I got your email today, by the way, and we can talk about that after. But the treatment for me becomes less about the exam, less about the pain, less about manual therapy, and it transitions a lot more to corrective exercise. So maybe we're spending 45 minutes just doing movement, just doing breath, just activating, lengthening, balance. There's so much. And that's what I love about teaching what I teach, because it doesn't just end when the pain is gone. And yeah, that's a huge part. And I don't mean to downplay getting somebody out of pain. That's one of the most rewarding things that you can do as a practitioner. But then it comes, okay, let's keep them out of pain. And how do we keep somebody out of pain? Let's maybe to get a muscle back online that has been offline for who knows how long.
The other thing is that when you're getting somebody out of pain, either from an acute or even a chronic pain condition, you focus on their getting their pain gone, but you don't usually do everything.
No.
So they come back in 2 weeks or a month, and their pain complaint is still gone. And then you have Eduardo's Dura presentation in the back of your head, and you say, let's make sure your neck is fine, and let me check your Dura. The patient goes, where's my Dura? Why are you checking it? What does it do? And it's, let's see. And their knee stops at 90 degrees, and their head tips back. And you go, oh, let's see what happens to muscle recruitment. Let's see what happens to your posture and your vision and your muscle recruitment if we treat scarring in the dura. What's the dura? So I don't know about you guys, but I don't usually do everything. We deal with what they came in for. And then when they come back, it's a little bit more leisurely and a less laser focused. So I think that's a great idea.
I think one of the hardest things to do though is because you have to be laser focused a little bit, because you want to get that person out of pain. And the birds, there's many birds, let's face it, there's not just one bird on the shoulder, there's many birds. The Eduardo bird, the Carol bird, there's a lot of different birds. But public enemy number one should always be getting the pain down and really trying to chase and figure out what is driving the pain.
Well, and fixing what's important to the patient, right?
Yeah, and it's very hard with the osteopathic manual therapy background, where everything is everything and everything's tied to everything. And you are looking at a fascial line or a fascial chain, or even biomechanically, that the knee is causing pain because of the hip. And now that the hip's rotated, maybe there's something from the disc. So you are chasing that. But even when you're doing that, the goal is to get the pain in the knee better. So sometimes you are looking, and that's a hard conversation to have also with the patient, because they're like, why are you looking at my hip? And I'm like, because that's why your knee is sore. Just give me 4 minutes.
Or why are you pressing on my quadriceps and my pectineus? I had a patient, she came in on Monday, and she's a cervical trauma fibro, and she's hypermobile. So I did those 2 neck to feet. And then she has one of her knees circled. And that made me check her quadriceps and her pectineus and her brevis. And she heard me mutter, it can't be that easy. And so we did 81 and 10, and their leg muscles and their trunk muscles turned to smush, and the knee pain went away because that it's
Yeah.
like it. So being able to think of all those things at one time is just a little tricky.
It is tricky. And that's why I have my notepad and I'm drawing diagrams and I'm taking notes. And because you can get lost in the weeds sometimes.
Yeah.
But it's very helpful if pain can be very helpful. So going back to that home maintenance, when somebody comes in and they're not in pain and they're not sure why they should be there, we have this conversation. I don't know why I keep coming because I'm not in pain. I'm like, don't you want to stay that way?
Yeah.
I
And
want you to stay that way.
it's always, I'm not in pain, and okay, there's your chart, and you had a 5-6 disc. How's your shoulder range of motion? My shoulder doesn't hurt. No, but raise your arm. Oh,
Right.
it goes to there, and then it gets a little tight, and okay, why don't you lay down, and then you put your finger in their armpit, and they go, ah, see? This is how we fix your shoulder and
Right.
prevent it from tearing.
And I think with a lot of people, once you start going down the assessment or even through the conversation, something pops up. Actually, now that you think of it, or now that I think of it, my foot is sore, or I have somebody that have had chronic ankle pain and foot pain for the longest time. It was that stubborn plantar fasciitis type of idea, did everything I could think of. But at the end of the day, our local podiatrist really just needed to put her in different shoes. And everything else then starts to fall into place and self-correct. And it was something I am not a podiatrist. I thought the shoes that she had were fine because she said her foot feels much better once she's in those shoes. However, we weren't closing the gap. And if somebody's wearing shoes 12, 15 hours a day, that's patterning, that's the environment, that's the stable state that you get stuck in.
Pronation control shoes are the first step with plantar fasciitis.
Yeah.
Although I had a patient that is like here this week, she broke her ankle, the talus and the tibia, distal tibia. And 2 years after that fracture, she had plantar fasciitis. Do you think the fracture and the plantar fasciitis might be connected? That's a possibility. It's just practitioners and patients can't think of everything at one time.
No.
And so that's why got invented next week.
And our amazing network of people that we have. There's so many times where I do reach out and text or email one of our many practitioners for just some quick advice about something. And I'm not looking for somebody to solve the case for me, but a lot of times, like, to have somebody's perspective can be super helpful. But let's talk about your patients that you had this week.
Oh, the thing I want to say before that
Yes.
is I got Dave Burke for the advanced for an hour. Okay. It's interesting. I had a patient that came in she was there for PTSD. Okay. And EMF sensitivity. Okay. And then we went through the linear history, and she told me that in I don't remember, 22 or something like that, she saw a craniosacral therapist who said, oh, you have PTSD, after listening to her history and whatever. And I said, what was the clinical license of the person who diagnosed you with PTSD? She was a massage therapist. Aha. Okay. Do you have nightmares? No. Do you have flashbacks? No. Early childhood trauma? Yes. COVID? Yes. Okay, and EMF sensitivity, 5G drives you crazy. And every EMF sensitive patient I've ever seen, once you get the vagus nerve working and get the midbrain calmed down so they're less sympathetic, because the EMF seems to stimulate the sympathetic nervous system. Becker found that. And so you get their vagus nerve working, and the EMF sensitivity, bunny ears, either disappears completely or goes to the point where it just doesn't bother them. So part of her problem was the fact that she was convinced she was EMF sensitive, but the fact that she was convinced now that she had PTSD. It's like, no, you don't meet any of the criteria. And a craniosacral therapist who's a massage therapist cannot diagnose you with PTSD. Did she give you a paper test to fill out? No. Okay. So we ran long COVID in the different organ systems in the brain and the vagus, and concussion in vagus, and additional time on 40 and 89 and additional time on 81. So quiet in the midbrain and increasing secretions in the vagus. And it's like magic. She left totally blissed out, came back the next day, still blissed out. So it was like, okay. And now most of it is just relief. We have 5G all over Portland where she's staying. It's not bothering her because now her vagus is working. That's pretty cool.
And to touch on, what you're saying, I think we've talked about this in a roundabout way, talking about when people come in attached to a diagnosis or attached to imaging or attached to something.
Frightened by it.
Right. And it doesn't always match up. One of the worst things I could see was my lumbar spine x-ray when I saw I had no disc, because I'm not symptomatic. But once I saw it, that's all I could think about while I was running. And because I was thinking about it, my posture when I ran, everything started changing, and it was crazy. Charlie Weingroff, when we had him on, did a really great job of talking about when patients are frightened by a diagnosis, we're given an incorrect diagnosis, we're labeled, or I didn't even say diagnose, but like labeling. Like, I think we have to be very careful about the labeling. And you did such a great job. I'll never forget when we did the first instructor's course, when you were talking about, we had a pretty large group, and but the practicum was the patient was prone, and somebody was having a conversation, and you jumped in right away and you said, you have to be mindful of the words you're using. Patient is in a hypnotic state, especially when they are prone. And I am so mindful of that. Even if we're using the terms, like if someone's, how does it feel? Like, you don't want to be like, ew, it's gross, it's sticky. Oh my God, what is that? We have to be mindful of the energy, the tone, everything that we're saying as clinicians.
And the whole hypnosis conversation, I wish I had time to find those slides or remake them, because anytime you make eye contact with a patient, they're in a state of hypnosis because they're mentally focused on your eyes.
Right.
And sensory deprived because they're not paying attention to the environment. And if the patient is supine, they don't have to be prone, and you have your hand on them, that's it. They're in a state of hypnosis. And the labels, the patients remember. So the patient will say, as part of their history, this podiatrist, orthopedist, neurologist, whoever said, this is the worst one of these that I've ever seen.
Right.
And that's what's stuck in the patient's head. I'm actually the worst. It's not fixable. It's not that hard.
Right.
Hang in there. Yeah. So
I've come to see in the years that I've practiced, like, just how much support people need. They need support in their journey. And whether that is trepidation about trying an exercise that has historically created pain, or getting rid of a label that somebody should have never given them in the first place, and trying to remain professional when all you want to do is turn around and scream into a pillow that's on the table, because a lot of it is undoing a mentality, a preconceived idea of what is going to happen. Especially you're talking about the subscap. How many times when I try to explain what I'm going to do and the patient rolls their eyes like, oh, I'm going to be in so much pain and this is going to hurt so much. And I said, how many times have you had this treatment with FSM though? And guaranteed you like 0. I said,
Yeah.
let's just try it and see if you find it any different. And they're like, are you gonna press harder than this? I'm like, I don't need to. Wow, you're going so slow. I'm like, because that's where the change is. Wow. And I know the psychology behind it. For every one bad thing that's happened, we need 9 good things to happen. It used to be 5, but our brains tend to be rewired more to that negative bias than we were 20 years ago. So 1 to 9. So I feel like FSM can expedite that. I feel like I can really do a 1-to-1. I don't need to do 9 subscap treatments. I can just do 1 good one with FSM. And then I'm getting all of their friends that have shoulder pathology in the clinic.
And if you have multiple custom cares, you have one program for just 40 and 396.
Yeah.
And then you have a precision care or whatever to unglue the subscap from the subscapular nerve, and the nerve never hurts because you have one machine just running 40 and 396.
Right.
And then concussion in Vegas is running on another one.
Yep.
So by the time you're finished, they're blissed out and their shoulder doesn't hurt. So that's about as good as it gets.
I have a question for you, but we'll get to some of the ones that wrote in first, because it looks like there's quite a bit here.
Yeah.
But let's go to the top. Pelvic congestion. 50-year-old female with vaginal ultrasound confirmation of pelvic congestion. So varicose veins around sex organs, pain that she and doctor will hope resolve with embolism. Beyond the basics, so she wrote 49 and 50, question mark, over 79. Anything else to do to support the resolution of pelvic congestion with FSM? I see you're in 2 weeks. We have not tried anything at this point. We'll go to that one first.
Yeah, that's the question that they didn't ask. What pelvic congestion does not come from space.
Right.
Yeah. So when did it start? What are your symptoms? What happened just before it started? And I had a C-section. I had an ovarian cyst burst. I have had endometriosis for years. Different causes. Pelvic congestion means that circulation around the sex organs, so in a varicose veins around the sex. Wow. Why? It didn't come from space. So why are the veins scarred? And then you have to remember that the veins and the lymphatics run right next to each other. So did you happen to have vaginal? What came before it? And embolism, you see the face I made as soon as I read it, is they introduce a blood clot to completely block that particular vein. Okay, where's the collateral circulation? If you block that one, where's the blood going to go? So they block that vein to force the blood to go to a different vein. But if you don't fix why that vein became varicose, I mean, there's a lot to unpack with that, Suzanne. I'd actually, beyond congestion and vitality in the veins, I'd look at scar tissue.
Yeah.
What's scarred in
Right.
veins, in the lymphatics? Where did it start?
Yeah.
She got an IUD just before, And what kind of IUD is it? It's copper. Aha. We have a frequency in the advance for copper. Is she sensitive to copper? Could that be causing inflammation that creates back pressure?
Right.
It's like you really have to ask why
Yeah.
and think about it and fix the cause, address the cause. Yes, you can. Varicosities, by the way, every vein has little valves that go like this. In a varicosity in the leg, and I assume in the pelvis, the little valve that prevents blood from regurgitating, the little valve breaks. So now instead of a centimeter of venous blood, you now have 2 centimeters, and that's a lot. And so it expands the vein. It's 10 pounds worth of venous blood in a 7-pound sac. And then eventually that pressure is going to break the next valve. And that's why varicose veins. And in the leg, it's pretty easy because there's a lot of collateral circulation. Look in Netter and see what the venous supply is in the pelvis. What are they going to embolize? Where does it go? What caused it in the first place?
Yeah.
And then torn and broken, you can't put a valve back that's not there. So the varicosity is fair enough. And there's nothing wrong with embolizing it, but it's going to show up someplace else if you don't fix why they had it. So there's just a little more history. Embolism is the only solution that the MD has to offer. He can't, it's almost like he's not interested in the cause because he can't do anything about it.
Yep.
So there we go. Post leg surgery, then 2.5, 3 weeks, 3 weeks in the hospital. Okay. Had blood clots, duh. At home and on oxygen. No, there's no contraindications for working with someone on oxygen. Why? So did the blood clots travel to the lung and he has a pulmonary embolism and now he's on blood thinners, so he doesn't have the embolism anymore, but he has scar tissue in the lungs. Is that why he's on oxygen? It's not much you can do about scarring in the lungs, but no, there's no contraindications for working on people with oxygen. That's good. Yay.
Next question. Thoughts on a client with diabetic wound, reduced to pencil size, but even with hyperbaric boot 5 times per week, it will not close. Yes, she tried bone healing and wound healing daily, put on antibiotics post-MRI, which she had to push for due to infection since last October, already amputated the 5th metatarsal of foot and index finger of hand, spinal stenosis, lung issues. And also ran additional protocols, hypoxia in the tissue circulation, blah, blah, blah.
They took off the whole 5th, the metatarsal is the really long bone, and the index fingers. Okay. The other thing I'd look for is, what's her tongue look like? Diabetics, generally the ones are in the feet. B12, I'm curious. That's last October. Pencil size. So pencil size this way. So about 1 millimeter, 2-3 millimeters. Hyperbaric 5 times a week, won't close. Wound healing, bone healing. The bones not, it's wound healing, mostly blood supply. Antibiotics.
The new wound is on the ankle, she's saying, and yes, reduced to a pencil diameter.
New wound is on the ankle. Huh. Interesting. What?
The wound went all the way to the bone.
Yikes. What? Spinal stenosis, lung issues. What anticoagulants is she on? I'd be curious about that. I don't know. How old is she? He, she? How And what's he's 80, okay. What's his A1C? Is his sugar under control? Is it out of control? How much alcohol does he drink? Is he taking B vitamins? That's a really good question. If so, he's, I don't know. A1C is good. I've never had anybody that the wound healing program didn't work on, so I don't know what the role is. Do you have an idea what the role is of spinal stenosis in diabetic neuropathies?
No clue.
Vascular supply. There's something tickling around on the inside of my head, and it's like blood supply to the foot. See if you can get the doctor to order a D-dimer. The D-dimer is the blood test that shows whether or not there's a blood clot. And it's like wound healing and a diabetic is all about circulation. It's just so you can increase the time. And the standard wound healing program is all 62 arteries. Diabetic neuropathies, as it turns out, are mostly about capillaries. So change 62 to 162 or add 162 and have somebody do a D-dimer. There's something up with the circulation especially between the knee and the foot. If his A1C is, stenosis, you can figure, but the wound is definitely an enigma. Try changing 62 to 162, treat the capillaries, and then rule out anemia. 80-year-old smoker, rule out anemia, but rule out blood clots. Good luck with that one, Annie. Let us know. That's why we have case reports.
Yeah, that's a big one. Leaf has a funny question. How do you relax hamstrings? Leaf, why are they tight?
There you go. And the other thing is, if the hamstrings are tight, put your hands on the quads and feel those. The way I relax the hamstrings is 81 and 10.
Right. And so that would be my first question. Is it one, because we have 3 hamstrings, right? So do you mean hamstrings all 3 on one leg, or is it bilateral? Anything that's bilateral, I jump right to the cord. Do not pass go. Do not collect $200. Things don't bilaterally get tight from outer space.
True story.
That was easy.
Yeah.
See?
And then please don't let them stretch them. Don't stretch. Listen to whatever John Sharkey said about stretching. Haha.
Yes. Yes. I get to see him in a few weeks. I'm off to Ireland a month from today. I'll be there teaching.
Isn't that exciting?
So exciting. Yeah. Yeah.
I can hardly wait to talk to you about.
Yes.
I accidentally happened upon a YouTube video of the RSD 10 years ago. First, you made me cry when he teared up and hugged you when his pain went away and he could walk comfortably again. Second, I was blown away that gluten triggered his RSD, inflammatory. In his knee where he had the nerve damage from the surgery. That's an amazing reaction, especially how it was localized. How is he doing? His pain was resolved long term, and he just never ate gluten again. He died in 2022 from medication that he thought was one thing and was laced with fentanyl. And so this little marble has his ashes in it. So I have him in different colors and he's always hanging around. But that was the coolest thing about that. I mean, besides getting a 13-year chronic RSD patient, pain-free, getting rid of fasciculations in the muscle, teaching him to walk again. If you go back and watch that video, I sneaked the towel, because it was his right leg. I sneaked the towel into his left ear when we did 81 and the sensory motor cortex. Didn't tell him what I was doing. And he's laying on his back and he looked up and he said, "Did the lights just change color?" And that was okay. The sensory cortex does indeed work. And reconnecting it to sensory and motor cortex allowed him to restore movement to the leg. Yeah, no, the pain was gone long term. He never had any trouble with wearing long pants or socks or anything. It's pretty fun.
Yeah.
Oh, okay. What do you recommend treatment for spinal stenosis? 91 and the minerals on the cartilage seem to have helped. Basically, spinal stenosis is usually at L3 in the lumbar spine. And so the facets get degenerated from the back, the discs get degenerated from the front, especially when the SI joints don't move and all the rotation happens at L3. And then that disc gets degenerated and the facets get degenerated because that's the whole lower spine should move and it's all happening at one level. So 9113 with the disc annulus, because there's always, to get stenosis, you have to have pressure from both sides.
Yeah.
I'd add the periosteum, and the anterior and posterior longitudinal ligaments, the dura, but the disc annulus becomes hardened. I have some concerns after my own personal experience about running scarring in the dura. Scarring in the disc annulus, because if scar tissue is the only thing that's holding it together, they're pretty desiccated by the time you're 91, but it's something. And then you treat the nerve pain that's going down his legs, because there's nobody in the right mind that is going to do a lumbar spine 360 or a laminectomy on a 91-year-old. That's just.
I don't know if she means the frequency 91 or the person is 91.
Oh, that's right.
Maybe.
Oh, 91. You're right. Sorry. I saw
That could be.
91. Got it. Depends on the patient's age.
Sure.
So there are some patients. So I had one patient a couple of weeks ago. I sent him home. It's like there's nobody in the right mind that is going to do surgery on your spine. This is a maintenance problem.
Yeah.
And here's your custom care.
Do you remember, this was pretty recent, where I was fighting with somebody about somebody who had shoulder pain, and I said it's not shoulder pain, it's coming from the neck. And I can't order an MRI, but we finally got somebody to do that. And I think I showed you the results, like the stenosis in her cervical spine was.
Oh, yeah.
So what's helped her, I would say 50% after one treatment, was running scarring and vitality in the dura.
Makes perfect sense.
It makes perfect sense, right? Like when you think about stenosis, I like how you just gave us that visual. There's pressure on both sides. And so I am also mindful of running things like scarring in somebody who has had a condition for some time, because and I learned the hard way. I think I presented this case a few years ago of the girl who had the really catastrophic motor vehicle accident that went down the 200-foot embankment and broke everything. And I was excited to give her relief, and I ran too much undoing of the scarring that was holding her neck together. And she would be in a lot of pain after she left. So I learned how to temper that. And then we had to, and to this day, we have to support her neck with rock tape after she leaves, just to give that proprioceptive feedback that this is safe and the muscles don't need to guard anymore. But running scarring, like I said, in a disc or in certain areas where there's been so much laxity and so much trauma, you just have to be mindful of that.
And the muscles have to be retrained to take advantage, to compensate for the loose ligaments, because ligaments don't stretch back. Okay, yay, Annie, he has a stent in the same leg, but they say it is working. You definitely need to get a D-dimer. But no, if he has a non-healing wound after everything everybody has done, the stent is in which artery, and there are 3 major arteries down the calf. Is the stent still working? How do they know? Have they done an angiogram on his leg? I'm not even sure that they can do that. But it has got to be a clot or a blockage someplace in the leg, in the arteries, to keep the circulation from going to the feet, right? That's wow, you guys.
We got through, those were a lot of questions. I want to make sure, I feel like at the end of every podcast, we're rushing to get through where the next courses are. And I feel like we just need to spend a little bit of time, especially after I read that email today, reminded me, we need to spend some time talking about the advanced this year.
Yep.
Because it's very special, and I want to make sure people is August. So I want to make sure people can plan for this, because it's going to be pretty amazing.
Yeah, it really is. I haven't written it yet.
Okay, that'll come.
But that's January. We have a masterclass coming up this weekend, and I think on the website it says advanced masterclass. You can be a core level student and never having been to the advanced and still take the masterclass. Doesn't have a script. It's whatever you need to feel like you have a better mastery of FSM. And then we have Rome in September. We have Costa Rica in November, 1st through the 8th, I think. And then we'll have a 5-day core in Troutdale in December. Yep. And then segue that into the core, the sports, and God bless the person who raised her hand and said, would you please do a 4-day advanced? So we'll take what I compress into 2 half days and expand it into 4 half days. So I get to create case reports, and it's more, how do you think about it, right? How do you take what you have on the advanced laminate and the experimental frequencies, and how do you mix and match depending on what you're treating? And it really is more going to be, at least I hope, that's my plan. It's more of a deep dive into how do I think about, what questions do I ask? Where do I look? How do I combine what I learned in the core, which is now 1,026 slides, with what is, I know it's cruel, and we'll be able to spend more time on the visceral section, which we really neglect in the core because their brains are full by Sunday. That's really going to be the fun part about Costa Rica. Is you arrive on Saturday, get unpacked, and then the course is Sunday, Monday, Tuesday, and then they take Wednesday off, and you're out in the middle of nowhere. So you get to go for a walk or go hang out in the hot tub or sauna or whatever. And then we finish up on Thursday and Friday. So it's just a kinder, softer course. That's getting there is interesting. So we're flying into Liberia and then renting a van so we can drive the equipment down. It's at Anamaya, which is, I guess, the nearest big, and that is in quotes, city is Montezuma. The directions will be on the website. But the advanced is, so you've got the rehab course Monday and Tuesday, and then you're advanced on Wednesday. And then we roll right into the 4-day advanced. And then the instructor training is on Mondays. So the future of FSM is actually the instructors. More and more people are taking it on video, but they need somebody to teach them how to use their hands, because you can see it, but until you have somebody guide you into how to feel it, it's a different experience.
Yes.
Cool. Did I do that?
Yeah.
Okay?
You did. Like I said, I feel like we're always just like blah, 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 at the very end. And for people who have not taken the advanced, It is, it's a lot. It's not so much of a jump, I don't think, from how the core used to be taught to the advanced, because for me, I was really starting to put things together at the advanced. And I don't think it was just about mileage. I think that's where the big shift came from, was why is it like this? Why is it not moving? Why does it not hold? The people that you get to talk to at lunch, in the hallway, who you're
Mm,
sitting beside, there is nothing like the in-person experience of, and Arizona is great and the food is great and like it's great, but it's like anything. I feel like the course is the stories that you hear, the cases that you hear. Yes, 101,026 slides, great for content, it's great for theory, but I feel like when you start talking to other people, just like what people are getting out of us doing this podcast, where you could be like, oh, I have a patient that's just like that. And what did you do? And what worked for you? And what didn't work? That's where the real learning, in my opinion, takes place. Because I've
that
been to the
much.
advanced now so many years in a row. And I love just sitting in the back and watching the sparks,
Yeah,
watching the conversation, watching someone's eyes just get wide, and
yeah,
totally, they start vigorously writing things down because you know of the 10 people that you have to call the minute you get back to your practice.
yeah,
So it's not just about what you're teaching, but it's also about the other practitioners that get to come and lecture. And I'm so grateful that Dr. Reynolds can come on the Sunday to talk about PRP, because what he's doing with orthobiologics and injections, and how I've been able to support his patients with FSM after, is mind blowing.
yeah.
So to just
There's,
get those experts that know how to explain what they do so well.
yeah. And then our own practitioners, the afternoon lectures, I'm filling up these spaces now, and Dr. Wood has got the assignment. He's our dopamine guy. What does the midbrain do? What are the dopamine precursors? That's in Bilica's neurotransmitter workshop, but what are the dopamine pathways in the
Yeah.
brain, and what can we do that'll affect them? And then Dr. Musnick will do a 3-hour morning the
Mhm.
first 2 days, because that'll be roughly the same.
Yeah.
And then the second 2 days, there isn't going to be an alternate.
Right.
Everybody's going to be together. But the other thing I enjoy the most about the advanced, and why it is, we have people now that take it live stream.
Yeah.
But the other thing I like about seeing people there in person is the hive mind. There is no other technique or technology where you will have 6 different clinical licenses all sitting at the same table, speaking about similar patients and what they can do with it. It's That's the best. So I sit at different tables when I have lunch,
Yeah.
and we get to have 4 lunches.
Yeah. Yeah, like you said, and just listen and learn. And it's such a supportive environment. Like I've been to a few other continuing education seminars, and nothing has been like that, where sometimes it turns into a bit of ego. It turns into, I do this and this is the only way to do that. And that mentality really turns me off, because the longer you practice, I hit 26 years in practice this month.
Wow.
The longer I'm doing what I love to do, the more I see there is no one way to skin a cat. So if you can have options, and you can, and that's what you have in abundance with frequencies, you have options. But let's talk about what options you should start with. Let's talk about what historically helps get the pain down the quickest. And like you said, that hive mind of, it's not, this is my way and this is proprietary and this is what I run and I won't share. There is so much sharing that goes on over that week.
Yeah.
And I think that's what makes my brain full, is just the abundance of selfless sharing.
Yeah. And it feels good. We've created a
Yeah.
community and a family. And somebody was asking me, one of the practitioners was asking me, it's when you fix the pain or you use frequencies to take away a pathology, why does it affect the whole body? And it's if you have a splinter in your foot, you have pain in your foot, but it affects your brain. It's distracting.
Yeah.
And your cerebellum has to change the way you walk. And then your brain is distracted both by the pain and the fact that how am I going to get this splinter out? And you still have to go to work and have a conversation, all that. And with FSM, when you correct a pathology, scarring in the abdomen, pain in the shoulder, because we can reconnect the brain and the body, and we have data that says we can do that, you can calm down the stress. Oh my God, my shoulder hurts. And you can reconnect it to the cerebellum. Oh, that works now. And you can reconnect it to the sensory cortex. That's been numb for 2 years. There's a thing there. Oh, okay. And sometimes I hear things from practitioners at lunch, and it's really, that works, huh? That's why the core keeps changing. It's like,
Right.
who knew that
Right.
124 and 710 works better than 40 and 710? I heard that from the instructors.
Yeah. But it makes sense when you talk about just how that annulus just gets like the micro tears turn into macro tears and just wear and tear on the disc. Yes, it's inflamed, but again, that's when they're thinking, why is it inflamed? Because it's torn. It
Yes.
needs repair and healing. And when
it's Diana Cross's lecture from last year.
That was like the biggest nugget of brain candy.
It made my brain hurt, but it's okay. I love it when she's right. She's amazing.
Amazing. And like I said, there's so many amazing people. Maybe you want to just list a few more of who's coming to the advanced too. You don't have to list them all, but I know you have a rough idea.
I am not going to drag. I have to look it up.
Is Juliana Mortensen coming back?
I think she should, but I haven't asked her yet.
If she doesn't, like people need to listen to her 2 talks the last couple years because it really helps explain current and FSM in she's such a great lecturer when it comes to those logistics.
There's a number of people I haven't asked yet, and Juliana Mortensen is one of them. So Guillaume from France is coming for either a case report or an hour. I haven't figured that out. I didn't write that down. So he's a PT from France, and Dr. Wood, Dr. Musnick. I'm hoping Jen Cisnowski will say yes, and then Juliana Mortensen and you, and we'll see who else suggests. I have a list.
Yes. Like I said, I'm very excited about Dr. Reynolds coming on. He can only come on the Sunday, so that's where we have to.
His last name was Massey.
Massey's his first name.
Oh, Massey's his first name.
Yeah.
Reynolds. Okay.
Yes.
Sunday.
And so it will be great because he will give you all the science about PRP and stem cell. And then I get to come in and talk about what frequencies I've been using to support what he does. So I think that's going to be great, but that's just me because I do think we're seeing a lot more people doing those types of work. And they're even being used like in the OR. So when patients are getting a ACL reconstruction, he's doing stem cells at the same time. And if they're doing PRP at the same time of a reconstruction, that changes your protocols for the post-op because we're not using 40 as much as we should. So that's my teaser, how I'm going to structure it.
So when they've had PRP during the surgery, you have to reduce the amount of time you spend on 40, or do you have to eliminate it completely?
I've eliminated it completely. And because we're dealing with bleeding, like there's a lot of other frequencies that you can use that I think are more important anyways.
Broken and increased secretions and increased vitality.
Yeah.
Interesting. Tell the gray dog I said hi.
Mm.
She's so cute.
I know. He's here to say it's 4:00.
Yes.
Give me dinner.
Alarm.
Yeah, but I'm glad we got out the educational stuff because I think that's important. So listen, people, like I said, it's the end of August. You have lots of time to take time off in March to come because it will be extraordinary.
I'm really excited about it.
Me too.
It's coming. Yay. And we have a few surprises for March too
Oh,
that I'm not going to talk about till March.
okay.
Okay.
All right. All right. And it's 4:00. So thanks everybody. These were a lot of great questions, a lot of wrinkles happening in my brain today. That's for sure. A lot of good synapses happening.
Yeah.
All right. We'll see everybody next week.
See you then. Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.